Hello, good evening. I'd like to just do some basic audio and video tests, and if I could, I'll rely on Erica again to let me know if you can see me and hear me. And we'll be starting in roughly 5 to 7 minutes. Hi, good evening, everybody. My name is Bill Hughes. We're coming to you from the Orthocardiology, the Mayo classroom. This is the sixth and last of the presentations for this series. It's been very well received between in the room and on the web. We've been between 80 and 100 people for every program. So that's been quite successful. So we thank you all for participating. And we thank Bayer, Servier, and Boehringer for supporting this in part. Tonight, as you know, we're going to be talking about the role of vascular imaging in the diagnosis and stratification of vascular disease. And I thought I would just start off, will I, Don? Yes. I would just start off with a brief little presentation. So the theme tonight is ditch the calculator, and I'm to that. And I'm going to tell you what it is that we do and how we look at the role of vascular imaging in addition to the role that can be played by the traditional calculators that we use. I'm a fan of the Best Science FRS calculator. This is a screenshot of a 61-year-old male who is a smoker, not diabetic, modest blood pressure, on blood pressure treatment, and cholesterol that's not particularly favorable. And you can see in the right-hand corner down that there's a 49% likelihood of a vascular event over 10 years. What is cool about the Best Science FRS is that you can select from a variety of interventions, and they're in the middle panel, and they range from physical activity to high-intensity statins and various other selections you can make. And so selecting high-intensity statin drops 49 to 31.9. With this particular software, you can only choose one intervention at a time, and I can tell you that the one intervention that always has the biggest impact is high-intensity statin. Other things are helpful, but going back to the principle that if you have cancer, you want the best treatment, you don't pick the things that aren't as good as the best treatment. And when it comes to vascular disease, high-intensity statin is the best treatment. I'll show you again. 49.1, 31.9. So in our practice, you will see when you get patients coming back to you from the various IVMC clinics, you'll often see that we have calculated an FRS. An FRS is in the intermediate to high range. In all likelihood, we're going to start lipid therapy if the patient's not already on it. Why do we start lipid therapy? We start lipid therapy because it actually works. So if you look at this slide, on the left-hand panel, you're looking at an intravascular ultrasound probe in a coronary artery segment. Murray's going to show us a lot about outside in. This slide is inside out. What this slide illustrates is that in the same segment, on the right-hand side, 6 months later, two things have happened. The lumen itself is 20% larger, the atheroma is 50% smaller, and most importantly of all, the atheroma is now more homogeneous in its constituents. Vulnerable plaques are made up of inhomogeneous components. And so the value of statin therapy has a lot to do with making the plaque more homogeneous, making the cap more solid, less vulnerable to injury, less vulnerable to rupture, and the patient therefore less vulnerable to stroke, heart attack, or sudden death. Why this matters in terms of how we manage patients downstream has to do in part with the standards for performing echocardiography in Ontario, which was published in 2012 and in 2015. I was a primary panelist. Mary was a secondary panelist. And when you look at the indications for ischemia testing in the absence of new symptoms, the standards refer to several possibilities, which you won't see on this slide, but here I've broken them out in the ones that are most commonly used by us. So periodic 2-year or so evaluation in patients intermediate to high global risk, and Murray's going to explain to you to what extent vascular findings define intermediate and high global risk. Reevaluation of patients with significant peripheral or cerebrovascular disease. So you will see often we will have a patient who's had a carotid endarterectomy, for example, and even though they don't have a symptom, we may do a provocative test on them annually. And then finally, of course, those who have established coronary disease by whatever means it was established, at cath, by CT angio, by previously abnormal ischemic testing, again, annual sort of testing. So our approach at the IVMC is no matter how we find your disease, whether that's through a wild elevated blood pressure or other things we make in the community assessment, whether we may do it screening people using vascular ultrasound,
and in any kind of setting it might be, including in malls and at public events. If we find this, we do this. We identify, we stratify, and we modify with the objective to minimize as much as possible critical vascular events. So that's my introduction to my good friend Murray Matangi. Murray provided me with his CV recently, and my printer ran out of paper as I was trying to get it all summarized here tonight. But I did notice the one thing that was missing was the number of times you've gone to a World Cup to cheer for the All Blacks. Is that something you can share with us?
Before this year.
This is the year before. Great. So Murray Matangi is a unique individual. He had a practice in academia for a period of time, and for the last 20 years or so has been the busiest community cardiologist in Kingston. Yet at the same time has almost 30 publications and over 100 abstracts, many of which were presented in Europe at ESC meetings in various key cities in Europe, and many of which dealt with the whole question of the value of vascular imaging in the detection and stratification of vascular disease. So, Murray, it's great to have you here. We're looking forward to your talk.
Yeah, so thanks, Bill. I'm happy to be here. Last time I was here, no one turned up, and I was a bit upset. But I called Bill and asked him why he didn't come. He told me it was next week. I thought Chuck was a bit vulgar, but it's not me. That's Bill's title. These are my disclosures. I divorced myself from all those people many years ago. So these are my goals. I want to convince you that most cardiovascular events actually occur in the people that you're looking at that you don't think are at high risk, because most of the events occur in low and intermediate risk, not the patient that you calculate the risk score and find out they're high risk. It's the other people. While cardiovascular risk scores are well validated, they're grossly underutilized. And if you're feeling a little uncomfortable, that's because they are underutilized. Imaging of atherosclerosis is simple, and it does provide important information about cardiovascular risk. And it's cheap, very cheap in Ontario. These are just some comments that I'd like to make. You cannot have an atherosclerotic event without atherosclerosis. That sounds simple, but it's pretty obvious. Prior to any first vascular event, the diagnosis can only be made by imaging. You might argue about that with bruits and ABI, and I would say the horse has bolted and has gone beyond the horizon if you're talking about bruits and ABI. It's a continuous variable. I think you're allowed some, but you're not allowed a lot. Atherosclerosis is everywhere, but more importantly, so is the absence of atherosclerosis. And that's where I think the key to imaging is. I've discussed the last one with Bill ad nauseum on the phone at times. I truly believe that if you image the carotid artery and you see a beautiful intimal medial thickening and no plaque, that patient does not need any cardiac testing to look for atherosclerotic disease. Everything in medicine has a beginning, and usually someone important has to die for us to make changes in what we do. And this beginning actually is in the Second World War. During the Second World War, over 400,000 Americans were killed in combat. During the same time period in the United States, 2.4 million people died of atherosclerosis, stroke, heart attack. And it's credit to the Congress then, as opposed to now, that they were thinking about what can we do in order to change this terrible epidemic of vascular disease, because they knew it was happening, they just didn't know what was causing it, they didn't know what to do. So it begins in 1933 when FDR became the 32nd President of the United States. And at the beginning of his term, in fact he had 4 terms, his blood pressure increased from 136 over 78 to 188 over 105 from 1935 to 1941. His Surgeon General happened to be an ENT surgeon because he suffered from sinus headaches. In 1943, he met with Churchill in Casablanca because Churchill wanted the Allies to concentrate on Germany, to go to the soft underbelly, as he called it, which was Italy. After the meeting, Churchill commented to his physician, Lord Moran, that the president looked tired, to which he replied, "Yes, Prime Minister." I suppose that's all you can say to Churchill. In 1944, he was admitted to the Bethesda Naval Hospital with shortness of breath and cyanosis, and his chest x-ray showed an enlarged heart. His blood pressure was 240 over 130. There were very few cardiologists in that time, but Dr. Bruin, who was actually a naval officer, was called in to examine him. He heard sonorous and sibilant rales, and those of you old enough used to call them that as well, a displaced cardiac apex, and an apical systolic murmur. He diagnosed hypertensive heart failure and gave him probably digitalis leaf in those days and salt restriction. That's all he had to offer. But for the first time, his blood pressure was actually treated with phenobarbital. So there was nothing available to treat high blood pressure, but at least he recognized that high blood pressure might be the problem here with the president. This is actually FDR's 4-lead ECG, and the CF actually stands for Canadian Forces. So in order to get into the Air Force in Canada during World War II and also the Allied Air Forces, you had to have a normal 4-lead ECG, not T-wave inversion in CF4 like the president had. Now this is where the conspiracy theories come. All the chest x-rays, and there were numerous chest x-rays of FDR, they all disappeared. And what my reading says that the Surgeon General probably got rid of them because he disagreed with the diagnosis. He thought the president had bronchitis. So in February 1945, they met with Stalin and Churchill at the Yalta Conference where they were deciding how to carve up Europe after the war. And Lord Moran wrote this in his diary. The president is a very sick man. He has all the symptoms of hardening of the arteries. I give him only a few months to live. The British are very astute clinically. And this is what happened to FDR. So when he had his hemorrhagic stroke at the age of 63, his blood pressure was 300 over 190. And that was in April, just before the end of the war. So the war ended May the 8th, 1945, and at the same time there were two senators drafting a bill called the National Health Act. It was passed by Congress in 1947 and the Senate later the same year, and Harry Truman signed it into law in 1948. They assigned $500,000, which is about $20 million in today's currency, to establish the National Heart Institute, which we now know as the NHLBI. And later the same year, they gave $94,000, which is about $1 million today, to establish the Framingham Heart Study. So these people were influenced by what had happened, not only to FDR, but to all the other people who were on the home front, who were dying at a much greater rate than the combatants during World War II. So it began in 1948, and in 1957 they found that hypertension causes a fourfold increase in myocardial infarction. 1961, smoking, hypertension, obesity, high cholesterol, all increased the incidence of stroke and heart attack. And what you're using, or a variation of what you're using, was first published in 1967. That's why I don't think it should be used. In 1968, the Framingham Heart Study was in trouble. It had only been funded for 20 years, and it was a direct intervention by Paul Dudley White, who spoke to President-elect Richard Nixon, who saved the Framingham Heart Study, which is continued today. So my first thing is, these are the common scores you see: the coronary risk score, the global risk score, the Reynolds risk score, Jupiter criteria, I've put in there the ARIC risk score, and heart score is there as a distractor because it's not a North American score, it's a European score. The third and fourth require CRP in order to make the calculation. So the first thing we published was in 2010, looking at the change in the risk score from a coronary risk score to a global risk score. What impact did that have on the use of statin in the population that we see? And to cut a long story short, it increases the use of statins by a factor of 2. The next thing we looked at is why do I think that risk scores are a problem? Acronyms are definitely a problem for physicians. They don't understand an acronym. There's no such word as ProCam. I looked it up in the dictionary. I looked it up in the Gaelic dictionary. I looked it up in the Celtic dictionary. There is no word. It just rhymes, I guess. So this was in Munster in the 1990s. Apologies to the females in the audience. So this is when studies were mostly done in men. It took over 10,000 men. It divided them up into high, intermediate, and low risk categories using the Framingham score. 10 years later, we find that 2/3 of the heart attacks occurred in the low and intermediate risk patients, and 30% of patients had no risk scores at all. So that's a problem. The patients you want, you're not capturing. This is another paper that was published in the American Heart Journal in 2009, where they just looked at a whole bunch of coronary disease admissions and took the serum cholesterol. 80% of these were STEMI or non-STEMI or unstable angina, and 48,000 had never had a previous vascular event, so this was their first event. When you look at the lipid levels in these patients, you find that 42% of them had lipid levels which at the time were below target. So these are people that when you see in your office, you're not going to capture. But they've got atherosclerosis. They didn't develop atherosclerosis on the day they had their heart attack. They developed it years before. That's where we want to get it. This is another paper from the Kaiser Group, which is one of the largest HMOs in the United States. And they looked at 200,000 men and women who had their first heart attack or first stroke. They then went back and looked at the previous Framingham risk score. 75% were low or intermediate risk. So these are the patients you're seeing. You say, you're okay. Well, they're not. So you should be totally convinced that most cardiovascular events occur in the low and intermediate risk patients, and those are the patients we're not capturing. The second thing we did was we did a survey of physicians in southeastern Ontario. This was a collaboration between Ottawa, Belleville, Smith Falls, and Kingston, and also, I think, Cornwall. Sounds like a Via Rail announcement, but that's the people that were involved. So we wanted to know, how often do people actually calculate the risk score? Is this a problem? So we surveyed 500 family doctors and got a response rate of 36%. We asked about their awareness. Had they heard of the risk score? We asked about whether they actually use the risk score, and they only had to use it once. And then we asked about what's the commonest method used to assess cardiovascular risk. So a simple question, have you ever heard of any of those scores that we've put down before? You just had to say yes or no. Didn't even have to have used it. So when you look at awareness, you find that, yes, everyone's heard of some risk score, or almost everyone. There's always someone who hasn't. The Framingham coronary and global risk score gets lower. When you add CRP into the equation, it gets lower. When you add the carotid into the equation, because that's what the ARIC risk score is, it's virtually unknown. And heart score was put in deliberately as a distractor because we expect it to be low because you shouldn't have heard it at all because it's a European score. So it shows that I think the answers we were getting were valid. What about, have you ever used it just once? You see the numbers drop. Another thing comes into the equation. Counting risk factors comes up as a way of assessing risk, which means you look at someone, I wasn't going to take you, Bill, but someone similar, who's sitting in front of you, you think, yeah, he's high risk. Then what is the most frequent method you actually use? And you find out all the risk scores drop, and counting risk factors is the commonest method in southeastern Ontario in 2013 of assessing cardiovascular risk. For women, heads you get a statin, tails you don't. For men, it's slightly better, but not much. So we decided that assessment of cardio risk scores are high, implementation is low, accuracy of implementation was not assessed, and it's the most frequent method is counting risk factors, which is just not good enough. So cardiovascular risk scores, while well validated, and they are well validated scientifically, they're not used. This is my baby. This is a good acronym. It uses one letter from each word, not like ProCam. Okay. I consider everyone except the first order, I would call us lightweights. Our majority I consider to be middleweight, heading towards light heavyweight. He's really doing really well with his research in vascular disease at Queen's. He's helping us out and we're helping him out. You know, an acronym and a name for a study should also have a concept. What is the concept of iceberg? The concept is that 7/8 of the disease is hidden. What you see is the people that are high risk, that anyone in this room can guess. What you don't see is what the captain of the Titanic didn't see, and that's that 7/8 of the disease is below the surface. So that's the concept of iceberg. So this was a simple study. It was just to determine the prevalence of carotid atherosclerosis in statin-naive patients who were referred for a routine echo. We also wanted to establish whether or not we could do rapid, brief carotid studies that would mimic a full study. So a certain number of the patients actually had a formal carotid as well. So it was just a calendar year. We excluded any patient undergoing stress echo because they would have a higher prevalence of vascular disease. We didn't want them, although that's where we do most of our work at the moment. Males under 40, females under 50, because those are the people who are not regularly thought of requiring statins. We didn't want people who are taking a statin because that would bias the study. And we excluded anyone who had any history of previous vascular disease or vascular intervention. And then, of course, there were people who didn't want to have the blood work, didn't want to have the carotid, so we had to exclude them as well. It was performed at the beginning of the ultrasound. Only 4 to 6 images were taken, no Doppler. IMT was measured in the conventional way, which I think is wrong, but that's fine. Plaque was just binary decision. Yes, it's present. No, it's not. 166 patients also had a formal carotid, and you'll see from the data that they are obviously not random. They're patients that we were worried about because we saw so much plaque that we decided they needed a formal carotid. But it still gives us some idea about whether the brief information is actually valid. IMT, some people get anal about how they measure IMT. It's got to be 1 centimeter from the flow divider, 1 centimeter in length. I think that's BS. This is what I call the elephant in the room. Everybody measures where it is. Everyone forgets about the plaque. To me, that's absolute nonsense. Why would you measure an IMT in this patient who clearly has a large plaque in the middle of his common carotid? It's totally misleading. Plaque, this is what we call P3, S2. P3 means it's calcified, S2 means it's irregular. You can see the shadowing from the calcium. That's how we know it's calcified. You can't get anything published unless you calculate the Framingham risk score, so we had to calculate the Framingham risk score. We divided into very low risk, intermediate risk, and high risk. I won't bore you, but we started off with 2,500 patients, end up with 560 patients, and most of those were excluded because of vascular disease. 190 refused to have the blood work, and 20 refused to have the carotid imaged. Again, 90% were patients who were either had a murmur, required their left ventricular function to be assessed, or had an arrhythmia. This is a busy slide, but just to point out a couple of things. The average age was 65, average LDL cholesterol 3.09, HDL 1.48, IMT 1.06, and 62% had plaque. This is an interesting slide for two reasons. One is it just shows that in both men and women, the presence of plaque increases with age. More importantly, I think, look how quickly women catch up. Postmenopausal, the first decade, they're equal to men, and they remain equal to men for every decade thereafter. So although women are somewhat protected prior to the menopause, after the menopause, they catch up quickly. I wish we had done 40 to 49 in women, because I wanted to see what it would look like on this graph. So I went into our database and selected people with similar criteria and shoved them in. I thought it would be less, but it's not actually the same group of patients that were coming through at the same time. This is the prevalence of carotid plaque according to Framingham. Remember that most of the people who are intermediate and sort of high-low risk are women. Most of them are women. Yet 50% of the women with a risk score between 5 and 10 have carotid plaque. 60% between 10 and 19 have plaque. I also point out that 22% of those who are allegedly high risk do not have any atherosclerosis in their carotid. Bill and I have argued about this on the phone. I think you should be able to move down a category. You can definitely move up. Currently, you can't move down. I think that's rubbish. You should be able to move down. You can't have an atherosclerotic event if you don't have atherosclerosis. Looking at the accuracy of the screen, the IMTs were similar. This is the correlation coefficient for that data. That's not the way you're supposed to present the data. It's supposed to be as a Bland-Altman chart. You can see here that there are a lot of points on the zero line, which means that they were equal. You've got a nice little shotgun blast there in the lower left corner. There are obviously outliers. There are two different people interpreting these. So obviously we're not looking at the same thing. But most of the points lie within 2 standard deviations of 0, which is all you're looking for, which means the tests are equivalent. So a large proportion of statin-naive men and women presenting for a routine echo with no previous history of vascular event have a high prevalence of plaque. So 61% in men and 62% in women. Now this is not a geographic study. This is a referral pattern study to a cardiology clinic. So people think there's something wrong with them. That's why they send us the patients. So I don't believe that this would be reproduced in a community study, but it is representative of what Bill and I see. And the other important thing was the abbreviated study is similar. This is stuff we've had trouble with because I think the reviewers don't like us. That's fine. It's not yet published, but we're going to update it. So this is the outcomes data, which I think is the most important stuff. So we just wanted to look at mortality, morbidity according to whether or not you have a normal or an abnormal carotid. So we looked at our database and took males between the age of 40 to 70, females between the age of 50 to 70. We've now extended to 75. I'll tell you why in a second. And it had a baseline carotid, formal carotid. We're now going to include the screens. And the minimum year of follow-up was 1 year. It's now up to 13. So normal carotid was IMT less than 1, no plaque. Abnormal carotid just means either plaque or increased IMT, or both. Same thing. Now, this is why they don't like us. I said, I'm not going to measure IMT the way they measure. I'm going to measure the way I think it should be measured. I think we should be measuring what we see in the common carotid artery, not what people say we should be measuring. Now, this is plaque area. This takes a lot more time. That's why I'm upset. We only get $30 for the test, but that's fine. I also changed the way we measure plaque area. 95% of plaque is in the bulb and the ICA. The rest of the 5% is scattered between the ECA, the common carotid, and the left subclavian. So if you're an academic, you want everything measured. If you're a clinician, like me and Bill, I want to do something that's going to give me an answer that I can do quickly. And this I really love. This was developed in Rotterdam. This is plaque score. Plaque score is even simpler. It literally takes seconds. You divide the carotid into 3 segments: common carotid, bulb, ICA. Plaque present, yes, no, 0 or 1. 3 segments, 3 each side, 0 or 6 is the plaque score. It's very quick, very simple, and you'll be impressed, I think, with what we found. I'm sure Dr. Jory is listening. He told me he would. He likes plaque height, and I'll show you why in a minute. I don't know why plaque height looks as good as what it does, but I'll show you some data later that it does actually look pretty good. So we're measuring plaque height, going back and measuring it. We excluded diabetics. We're going to include them in the new analysis. I hope Arm is listening. I think that ISIS is going to give us outcomes eventually when we present all the data to them. And that's the only way we're going to get the numbers we've got and the outcomes that we need. Because the stuff at right is what Dave Armstrong did the old-fashioned way. So we use the usual stats. I'm not going to bore you. So with this first paper, the patient was followed for a mean of 3.5 years, approximately 1 to 8 years. The new analysis will be 1 to 13 years. There were about 1,500 patients. 1,253 had some estimate of plaque burden, so plaque area or plaque score. And the new analysis will be actually over 12,000 patients, made up of 5,000 screens and 5,000 full carotids and 7,000 plus screens. So this is what we saw. I'm totally convinced if you have a normal carotid, you're going to get hit by a bus, drown, get cancer, stabbed in the heart by a lover or something, but you're not going to die of a stroke, thrombotic stroke. You're not going to die of a thrombotic heart attack. You're not going to lose a leg, because we only saw 2 events. I think we probably missed the plaque. That's what I think. So there were no cardiovascular deaths in the normal carotid group. We had 2 drownings, which upset the reviewers, like, did they have a cardiac arrest? Well, they had water in their lungs, so I don't know. They drowned. That was a big problem for the reviewers, the 2 people who drowned. So there were 64 altogether and 2 in the other group. The most important slide we didn't load, because this is the Kaplan-Meier curve.
People at home can see it.
Which was before that slide. So a normal carotid at baseline is associated with an extremely low cardiac event rate. Now I've actually calculated that. It's 1.6% over 10 years. And for an abnormal carotid, if it's just IMT thickening, it's 2% per annum, so 20% over 10 years. If it's a plaque score of greater than 1, it's 2.6% per annum, 26% over 10 years. Excuse me. If it's plaque area, it's 2.8%. If the plaque area is above 24.3, I think it is, millimeters squared, then the event rate is 28% over 10 years. So what we decided to do then was see if we could work out which of these 3 methods, IMT, yes, no, plaque score, or plaque burden was the best way to, or plaque area was the best way to look at it. The way you do that is that you construct ROC curves and find out where the best sensitivity specificity is, and that's your cutoff for yes, high risk, no, low risk. So this is plaque score. So it turned out 0 or 1 was a low risk category, and 2 to 6 was a high risk category. The area under the curve is 0.72 almost, so it's not bad. It's within the physiologic realms of what you expect. So at 5 years, the difference between the two is about 10%. So 97% survived and were event-free at 5 years in the group who had a plaque score of 0 or 1, compared to 87.1% for the plaque score of 2 to 6.
What's the average age of this group?
65.
So this doesn't look like an O'Leary curve. O'Leary is more impactful.
I forget O'Leary. So O'Leary is a geographic study. It's a population study. It's a non-referred study. So his data refers to Peterborough proper. This refers to Kawartha Cardiology Clinic, because they're different populations. They're selected because they come to see you. This is the way that Kaplan-Meier curves are presented these days. The real stuff on the left is 0 to 100%, and the false stuff on the right is when you change the y-axis to make it look better. So for IMT measurement, it turned out to be 1.15 millimeters, which really upset them because 1 is the cutoff for everything else. And the area under the curve was 0.68. So when you do that similar sort of stuff, 99% survived, event-free, compared to like almost 90%. So all these curves look fairly similar. Plaque area, which is what I really like. I think it's going to work out to be one of the better ways to assess risk. Turns out 23.8 millimeters squared is where the RAC curve gives you the best sensitivity specificity. So that's what we use for the cutoff. You draw your Kaplan-Meier curves, same sort of stuff, 96.8, 86.2. These are all highly significant values. Now, this is where the good stuff comes. So then you run Cox proportional hazard modeling to find out which of these parameters actually is the best. It turns out to be plaque score, which is good for clinicians because, as I say, 30 seconds it takes to measure plaque score. It takes me 15 minutes to measure plaque area. Being female was also a negative risk factor, so their risk was lower than men. I think because of the age. We're talking about people who are only aged 65. This one won second prize at the American Society of Echo, not first. I don't know why. Anyhow, what it shows you is that this is a continuous variable. So this is the Kaplan-Meier curves according to plaque score. And obviously the worse the plaque score, the higher the event rate. So a normal carotid at baseline is associated with a very low cardiac event rate, 0.16% per annum. An abnormal carotid is associated with a significant increase in cardiac events, including cardiovascular mortality of 2 to 2.8%. The greater the plaque burden, the higher the cardiac event rate. So now we've got you convinced that, events occur in the people you don't think they're going to occur in. Risk scores are a waste of time because you're not calculating them. Imaging is the best way to look for atherosclerosis because it's a disease. We don't give people blood pressure medication without measuring the blood pressure. Why should we give people statins without checking whether they have atherosclerosis or not? It makes absolutely no sense to me not to be looking for atherosclerosis. It's definitely cheaper, infinitely cheaper. Tenfold difference in the cost of the machine. I haven't said a word about CT coronary scoring or CT coronary angiography, but I can tell you that our outcomes data is almost superimposable to calcium scoring, and it's cheaper and more widely available. So now you know it's the best way to do it as well, right? It's cheap. This is why Dr. Jory likes plaque height. So this is a study that was published in 2013, which I'm a co-author, where we looked at plaque volume. Plaque volume is obviously the way to go, but it's not practical. Plaque height worked out to be pretty good. So the area under the curve for plaque height is 0.745. This study is looking at people going for coronary angiography and looking at their carotid first to see who has a significant stenosis. It worked out that plaque volume was highly predictive of an abnormal coronary angiogram. And I think it was 90 femtoliters or whatever it is, a little volume anyway. Thank you.
Well, okay, before we start the question, I want to call comments. We've done the non-cardiac office, same thing. We've done it in the family doctor's office, we've done it in the mall, we've done it at events like Royal War Fair. Uniformly, women over 50 have 70-80% identifiable disease, men over 40. Your people are rich in HDL. We don't get average of 1.48 HDLs around here.
I'm going to say you don't look. So the thing is that no, I tell you what, you look at a cholesterol level, and you see a low HDL, you say I've got a low HDL. But when you look at a cholesterol level and you see a high HDL, it passes your vision. It doesn't come into your consciousness. I would say if you were to look,
dictate them all. Anyway.
No, if you were to look at your data.
Okay, I'm gonna look next 200 patients, and we'll have this conversation later. So one other thing I would make a comment on, though, Murray, I would say this: that while I agree in general that if a patient has nothing in their neck, it's pristine. If they have other risk factors, we look at the legs too, and sometimes you find plaque in the legs and there's nothing in the neck. That's the disease.
I'm going to disagree.
Okay.
I think that plaque is ubiquitous, okay? Which means if you find it in here, you're going to find it everywhere. It differs in different vascular beds. So, for example, you might have claudication and have mild plaque in the carotid. You might have had triple bypass and have mild plaque in the carotid and normal ABIs. I don't believe that you can have a completely pristine carotid and have disease anywhere else in the body. I don't believe it's true.
Okay, I'll show you. All right, so obviously we differ a little bit, but not very much, and the importance of the vascular imaging contributing to the overall risk evaluation. So let's open up to questions on the web. Send them on in. Hardy?
Okay, so if we set a patient now, is this becoming secondary prevention, and should we be putting them all on aspirin?
Who are you asking? The answer is yes. So, you know, the true definition of primary prevention is someone who's never had an event. But a lot of people have the disease without having their first event. So if you find plaque anywhere in the body, you're talking secondary prevention. Statin, aspirin, minimum.
And on that, it's interesting, just to remind you that when we talked about the ESPRI study a few weeks ago, the risk in the control group was really low. 11% over 10 years worked out. So that's not the type of people we're mostly seeing. It was a very low risk group in comparison. Mike, did you have a question?
So one of the big arguments has always been, fine and nice, association is everything. We don't yet have the large randomized control trial that says carotid imaging statin outcome. And so a lot of people will argue that we shouldn't do it until we have that trial done.
Yeah, I actually agree. So before Jupiter was even thought about, I approached whoever makes Crestor to say, we should be doing a randomized trial based on the carotid, right? Randomizing them to Crestor, whatever, placebo, whatever. You can't do that now. All the guidelines call this disease that has to be treated. I agree. I'm not sure what the answer is, but it was never going to be tested, I don't believe.
It's the only challenge that exists, because I certainly agree with the data, and I certainly can't say that not treating the statin is the right, that you need to. But I just have a tough time quantifying benefit for patients when we have that level of conversation.
The other thing I would say is, do you take a statin away and an aspirin away from someone who has a normal carotid?
That's a really good question.
I do. You know what I say to them? If my carotid looked like that, I wouldn't take the drug or the aspirin. I could be out in left field. You know, 12% of diabetics have a pristine carotid. Not all diabetics die of heart disease. Only 4 out of 5, not 5 out of 5.
No, and so now you're about talking to them and saying, okay, well, you know, I use the analogy that if I took 100 of you, I would prevent 20 heart attacks, but 80 of you would take drugs and not.
Yeah.
And I can't tell you who that is.
No, exactly.
So I just want for people at home. So what the talk is here about is in part about what is primary prevention. But Mike, I remind you, with the scenario you described here, whether you do it or not, that's the WASCOPS trial. And you know those people hadn't had a clinical event. Now you can make the argument everybody in Scotland has vascular disease, and that's probably true. But that's the question you were asking. If you saw that, would you have outcome data? Well, WASCOPS is outcome data. And the other point I think I'm pointing about WASCOPS that I think is probably the most interesting thing of all is that in the group who took pravastatin for 5 years and then didn't take it after the trial was over, they're still living longer than the people who never took it. And the people who lived the longest are the ones who took it in the active arm and stayed on it after. And I think that's pretty good primary prevention data.
Yeah, but once again, WASCOPS was looking at cholesterol, it wasn't looking at carotid.
Right,
See,
but I agree with you, but I'm pretty sure if we'd gone over there and taken a peek at everybody's carotid, we would have found it.
It's just it's not a disagreement in any way with this. It's complete agreement. It's simply how do you say to the naysayers? What do you say to the naysayers who say, well, you don't have that, so you shouldn't do it?
You know, I would say
So
that
just to repeat the question is, so what Dr. Hart is saying is you know, if a patient is reluctant, what hard evidence do you have to draw on to persuade them, I think is the question.
I would say to them, you know, you're sitting down on a Sunday morning, reading the newspaper, having a cup of tea or coffee, dunking your toast in it like I do, tea, and you look at the paper and say, oh my God, John died. I didn't even know he was sick, right? That's the bottom part of the iceberg. That's what I say. I often will turn my computer around to the patient and just say, have a look at this. They look, what's that? I said, that's plaque.
All right, another question, and then Jim?
Just for a point of trivia, Frank Melrose' son was a general in Omaha Beach, and he died of an infarct 4 days after landing.
Okay. Okay, Don's just going to check, let Don step in there and check if we got any web participants coming in. And Jim, I think you're next. Oh, John, was that you? Sorry.
I heard a similar talk at the heart and stroke meeting maybe 5 years ago. I don't know whether that would be
No.
a similar final word on it.
No. John?
Bill, in one of the earlier weeks, you talked about our carotid screening and mentioned that almost everybody that we screen has plaque. And Murray suggested the same thing, and his 7-year-old who was 80 plus that had plaque. Just to play the devil's advocate, does that mean that the whole country is sick, or is there any way that getting old is reflected in carotid disease?
Okay, so Dr. Easter's question is it normal to have plaque? And my position would be, I don't know Mary's position, but my position is never normal to have plaque. It's never a good thing to have plaque. And the more you have, the worse that is. That said, there are people in their 80s and 90s who have plaque and they seem to be doing okay. And should you start them on a statin at that stage in their life? I don't know the answer to that, but I give them the option. I say to them, to the extent that we understand how this disease works, we believe that if we get your LDL cholesterol down as low as it can be, the chance of you having a ruptured plaque will go down. The chance of you dying suddenly from a heart attack or stroke will go down. You might live longer to die of something else. What do you want to do? And I think that's the only thing you can do is have that honest conversation with people. We don't, and there's never going to be a large clinical trial of 90-year-olds. It's never going to happen. So you have to take physiology and practicality and let the patient be part of the part of the decision making.
John, what I would say is that interval thickening is an aging process. Plaque is not.
Can I ask you a question? It is my observation, whenever I investigate the patient, they had erectile dysfunction, the coronary disease assessment came back normal totally. Then I was monitoring their testosterone level because they have the erectile dysfunction. And I found them, even though their investigation was normal, when the level was going down, they had a heart attack in 4 or 5 years. Is there anybody looked into this, the level of the testosterone level and the prediction of the heart attack or incidence?
Not that I know of, but it sounds like it's inversely proportional to age. Right? As age goes up, testosterone goes down, and as age goes up, risk goes up. So
just to repeat the question, it was whether there is any scientific work going on the observation that as testosterone levels fall, there's an increased risk of vascular events. None of us know the answer that that's true, that that's being investigated, but it's, as a practical level, it's the inverse of age. Any other questions? Yeah, Judith.
So where should we be sending our patients for carotid Dopplers?
To the vascular lab. So the question is, where should the patient go for to the vascular lab? That's the resource that we have. I think the new generation of trainees are going to be much more comfortable with doing ultrasound out of their pockets. There's been some trials looking at that and finding that people can detect vascular disease in the office setting, and we did it as part of the studies that we did.
I would say, who should you send, not where should you send. So you should send all intermediate patients. If you calculate the Framingham risk score and it comes out intermediate, I want to know whether that patient goes up, or in my case, can it go down? I believe it can go down. I always write in my reports that I think it can go down, but the conventional wisdom, which is my cliche, is that you stay where you are.
And it guides therapy.
Pardon?
It guides your therapy.
It guides therapy, and it guides the frequency of investigation as well.
So when I'm doing this Framingham risk, and I do it fairly regularly, they may have a really good LDL, but because their HDL is very poor, they have a high Framingham risk. I don't know what to do about them. So maybe I should be sending them for carotid Dopplers.
So the question, Dr. Armstrong, is if somebody has a high Framingham on account of something other than high LDL, for perhaps a low HDL, maybe they're a smoker, maybe they have family history or something, be different things. The answer to that is, there doesn't appear to be a floor for how good you can get the LDL. And the PCSK9 studies are telling us that LDLs of 0.7 and 0.6 are beneficial. So my practice would be, if there's plaque disease and they have an LDL of 1.3 or 1.6, I treat those people.
I can tell you where age is helpful. So if you have a 75-year-old male in front of you, 95% chance he's high risk, without calculating anything. If you have a 75-year-old woman in front of you, it's 90%. So those patients, you can eyeball them, but below those ages, you can't. They're sitting on the iceberg, that group.
Brendan?
No, I was thinking, my next question from that group is, it seems to me that group empiric practice of a statin and aspirin seems reasonable if you got 90 and 95% risk pre-carotid screening. Do you actually need to do carotid screening in that group to justify aspirin? You can justify statins currently on Framingham risk score, but not aspirin, right?
There was one part missing for I should have said. That's people who are referred to a cardiology clinic. You can't separate the fact that the patients that you see and the patients that I see are different risk as soon as they come through the door. So I should have said, actually, that only applies to Bill and I, really. It doesn't actually apply to you.
So the question had to do with whether, if you had a very high Framingham risk, for example, 50, 75, whatever, is there a need to do the vascular imaging? And I would say to you that the need to do the vascular imaging is not to ensure that you're doing the right thing. It's to guide the frequency of what else you do. So in the case of ischemia testing, for example, if somebody has had a carotid endarterectomy with a 95% stenosis in their neck or their legs, that's a patient who, by Ontario standards, would be entitled to an annual ischemia test. On the other hand, if someone had relatively mild disease and otherwise was controlling risk factors, that would be someone every 2 years as an intermediate risk patient.
And also the justification for aspirin is just the other thing.
So we talked about that, and I don't think you're at the meeting, Brendan, was asking for the justification for aspirin. So in October of 2018, when 3 papers were published in the New England Journal that called into question the role of aspirin for primary prophylaxis, I actually was in contact with the author of the Esprit paper, J.J. McNeil in Melbourne, Australia, and I asked him a number of questions around that. And there's 3 takeaway messages that he gave me. One, they don't know whether or not their data supports the idea that if you have somebody on low risk who's already on aspirin when they hit age 70, they don't know whether it should be stopped. The second message is they don't know what to do about patients that are demonstrably at much higher risk. So somebody with a PV event or known to have PVDs or whatever, they don't know what to do with that. And then there's the whole thing in between is the intermediate to high risk patients by other ways of calculating and assessing, and they don't know what to do with that either, because in Esprit, the calculated 10-year event risk turned out to be 11.1% in the control group, and patients 70 and over. That's astonishingly low risk group of patients 70 and over. I don't know who those patients are. They don't live in Peterborough. I'll tell you that. Those people do not exist in the area in which we practice. So I think it's raised more questions than it has answers. I think what you can say fairly about the series of papers that appeared is that if you have a 70-year-old who otherwise appears to be at low risk, who is asymptomatic, and doesn't have a large plaque burden, and the only way you're going to know is to look, then you may be okay not putting them on aspirin. I don't know if you feel different about that.
I was thinking of something else while you were talking.
Oh, good. Well done.
We have a question from the web.
Okay, a web question, Don. Am I able to read that?
It's just in the bottom below that closed presentation.
Okay, so this is a question I think Murray should answer. And this question is the presence of plaque equal to having had a CV event? And I think what the questioner is asking when it comes to decision making about therapy.
It requires the same treatment as having a CV event. So they're identical in terms of what you're going to do to manage the patient. If you have a lot of plaque in the carotid, you need preventative therapy. If you've had an event, you need preventative therapy. So I think of it as the same.
Okay. Seth?
Sorry, just quickly, from a practical standpoint, then, if we were to send something to the vascular lab with, like, Alan and Bob, if we put screen for plaque burden, how would they report that? Would they report that plaque?
Okay, so the question that came is in the local vascular lab, if a question of plaque burden were asked, well, how would that get reported? So we send hundreds of patients to them every month. The report comes back as a diagram, which is way better, in my view, than many reports which are simply narrative. And so you can eyeball that and see. So how I look at those reports is, if somebody has a long plaque of 30%, from halfway up the common to halfway up the internal, compared to a little speck of plaque at the bulb or just in the internal, I consider that long 30% much more significant and concerning than a little fleck of plaque. I tell patients that there is evidence for atherosclerosis, and if you want to be aggressive, here's what we can do. I don't do much discussing with the long 30% plaque. I say this is what you need to do. The one shortcoming that we have, and we talked about, is that they don't, when they talk about intimal thickening, they don't always quantify it, and that it can be a problem in terms of what Murray was showing in terms of survival curves over 5 years, depending upon the amount of vascular disease that's observed. And I think Rick was next.
Yeah, it was the same question, actually.
Okay.
Plaque burden, because we all see the diagrams, we say, okay, less than 1 to 50%, is that?
Yeah, so the reason is, so Rick is asking why they say 1 to 50%, because they're basing it on the velocity of flow. So the Doppler component of the test. And so we know that we don't have obstruction at 50%, so there's no acceleration of velocity or insignificant. So that's why it's reported in that way. But what you need to do is take your eyeballs and look at that vessel. And if you see a lot of plaques in a lot of places and over long segments, that's a concern. And so to me, that's a patient who should be treated and should be in some form of surveillance regarding disease elsewhere, most particularly the heart. And somebody had their hand up here, I think. No? So I think that may be the last question. We have no additional questions from the web. So let me close this series of meetings by saying it's been a really great experience for us here at Cardiology. I appreciate the support of Dr. Reeser and Dr. Hartley, Dr. Wagner, Dr. Doucette. And the news track. And I want to thank, we thanked the chef at the beginning of the meeting, but I want to thank the wizard of technology, Don Flagler, who has made this happen for everybody at home and everybody here. So for those of you at home, thank you for joining us. You will soon be hearing from us about ideas for next season, and we're looking for people to participate on a committee to take this going forward in the future. So thank you to everybody who's been a participant. Thank you to all our speakers. Thanks, Murray. Okay. Great night.
Bill, if you don't mind, I'd like to make a comment as well. Last week when